Okay, let's jump right in. You know how your body just handles stuff, like keeping your heart beating, making you breathe, digesting that last meal, all without you ever sending a single conscious command.
Right. It's this amazing, complex autopilot system running in the background.
It really is.
It's called the autonomic nervous system, or ANS for short. And it's basically split into two main branches that they often work in opposition to each other.
Okay.
You've got the sympathetic nervous system, which kicks in for fight or flight, getting you ready for action.
Right. The adrenaline rush feeling.
Exactly. And then there's the parasympathetic system, the rest and digest side. It helps you calm down, conserve energy, handle the basics.
So the deep dive we're taking today, using all this great material you've shared, is really about how certain medications mess with, or rather interact with, this very system. We're specifically zeroing in on two big categories, adrenergic and cholinergic drugs.
And our mission really is to unpack what these drugs actually do. It's about understanding which side of the ANS they influence and how. Do they push the gas pedal on fight or flight, or do they hit the brakes?
Or do they boost the rest and digest functions, or maybe block them?
Precisely. We'll pull out the essential takeaways from the material so you get a clear picture of this. Well, it's a really crucial area of pharmacology.
Definitely.
Yeah.
So let's start by setting the stage properly with that autonomic nervous system itself.
Yeah,
Because everything we're about to discuss kind of hangs on these two branches, right?
absolutely.
Mm.
So the sympathetic system, the fight or flight one, it mainly uses chemical messengers like epinephrine and norepinephrine.
Ugh.
It's all about mobilization, increasing heart rate, raising blood pressure, getting more blood flow to your muscles. Think of that surge you feel when you're startled or maybe exercising hard.
Got it. And the parasympathetic system, the rest and digest, sometimes called feed and breed, I've heard.
Yeah, that captures it too. It uses a different messenger, primarily acetylcholine or HE. This side is about conservation and maintenance.
So slowing the heart rate down.
Right, increasing digestion, helping you relax after the stress passes. It helps you wind down.
Okay.
And the key thing, the really crucial part for understanding these drugs is that these systems work because these neurotransmitters bind to specific docking sites called receptors on cells throughout your body.
Okay. Like a key fitting into a lock.
Exactly. And the drugs we're talking about, they essentially either mimic the action of these natural neurotransmitters, those are called agonists, or they block the neurotransmitters from binding to the receptors. Those are the antagonists.
Gotcha. Agonists mimic, antagonists block. That seems like the core concept.
It really is.
Okay, so let's dive into the adrenergic side first. That's the one linked to fight or flight using epinephrine and norepinephrine.
Right. So these neurotransmitters, they primarily interact with adrenergic receptors, and the material highlights four main types we need to know: alpha-1, alpha-2, beta-1, and beta-2.
And where they're located makes a big difference in what happens when they're stimulated.
Huge difference. For instance, alpha-1 receptors, they're on blood vessels in your eyes, bladder, prostate. Stimulate them and things tend to constrict.
Okay.
Beta-1 receptors are mainly in the heart and also the kidneys. Stimulating these, that increases your heart rate and how strongly your heart pumps.
Makes sense for fight or flight.
Totally. Then you have beta-2 receptors. They're on smooth muscles like in your lungs, your GI tract, the uterus. Stimulating these causes relaxation. So think opening up airways in the lung.
Bronchodilation.
Exactly. And alpha-2 receptors, these are interesting. They're often found in the brain, and stimulating them actually inhibits the release of norepinephrine.
Wait, so stimulating them actually lowers the fight or flight response in some way?
Kind of counterintuitive, right? But yes, it can lead to things like lower blood pressure because it dials back the sympathetic signal overall.
Huh. Okay, so let's talk about the drugs that mimic this whole fight or flight system then. The adrenergic agonists, they speed things up.
Right. They're also called sympathomimetics. They mimic the sympathetic system. A classic example from the sources is epinephrine.
Adrenaline, basically.
Pretty much. Now, what's really notable about epinephrine is that it's non-selective,
Yeah.
meaning it doesn't just pick one receptor type. It hits alpha-1, beta-1, and beta-2. It just activates everything.
Wow, okay.
And it's also something called a catecholamine. That just means it acts really fast, but the effects wear off pretty quickly, too.
And because it hits all those receptors,
Yeah.
the effects must be pretty widespread and powerful.
Extremely. Which is why it's a cornerstone in emergencies. Think anaphylactic shock, cardiac arrest, really severe low blood pressure, even life-threatening asthma attacks or bronchospasms. It gives you that massive system-wide boost.
But that also means the side effects probably feel like you're really, really hyped up.
Exactly. Racing heart, high blood pressure, feeling shaky, nervous, palpitations, sometimes trouble sleeping, just like a major adrenaline surge.
And the sources also mentioned it can affect blood sugar.
Yes, that beta-2 stimulation can actually cause your blood glucose levels to increase, something to be aware of. And while it's life-saving, there are cautions mentioned for conditions like certain heart arrhythmias or glaucoma, though often in a true emergency, the benefits outweigh those risks.
Okay, so that's epinephrine non-selective, fast, powerful. How does that compare to something like, say, albuterol? The material contrasts them.
Good comparison. Albuterol is different in a couple of key ways. First, it's a non-catecholamine, so its action starts a bit slower, but it lasts longer than epinephrine.
Okay, slower onset, longer duration.
But the really big difference is that albuterol is a selective beta-2 agonist.
Selective, meaning it doesn't just hit everything like epinephrine.
Exactly. It primarily targets those beta-2 receptors, the ones that cause smooth muscle relaxation, especially in the lungs.
Ah, so it focuses on opening the airways?
Precisely. That makes it incredibly useful for treating asthma and bronchospasm because it provides that needed bronchodilation without causing as many of those intense system-wide side effects you get with epinephrine. It mostly leaves the alpha and beta-1 receptors alone.
So much more targeted. Fewer side effects like the racing heart.
Generally, yes. You might still get some tremor or a bit of increased heart rate, especially at higher doses, but it's usually much less intense than with epinephrine because the primary target is the lungs.
So these adrenergic agonists, they're basically for situations where you need to ramp things up, low blood pressure, slow heart rate, airways clamp down.
That's the core idea, boost the sympathetic functions.
But you really have to watch for those signs of overstimulation. And there was a really important warning in the materials about AV administration.
Yes, absolutely critical. Adrenergic agonists, like epinephrine given intravenously, are designated as high-alert medications.
High alert, what does that signify practically?
It means there's a heightened risk of causing significant patient harm if an error is made during administration, like the wrong dose, wrong rate, wrong concentration. The consequences can be severe because these drugs are so potent.
So intense monitoring is key.
Constant monitoring of vital signs, heart rate, blood pressure, respiratory status, and patient education is vital too. Teaching them and their families what signs of overstimulation look like, how to use devices like inhalers or EpiPens correctly, and when to report problems.
Okay, that makes a lot of sense. So if agonists are pushing the fight or flight gas pedal.
And then adrenergic antagonists are hitting the brakes.
Got it. Blocking the action, slowing things down,
Yeah.
symptolytics, right?
Exactly. They block the sympathetic response. The classic examples everyone knows are probably the beta blockers, the drugs that often end in elolol.
Like propranolol, atenolol, metoprolol.
Those are key examples. Now, propranolol is important because it's non-selective. It blocks both beta-1 receptors, primarily in the heart, and beta-2 receptors, like those in the lungs.
Ah, so like epinephrine hitting multiple targets, propranolol blocks multiple targets.
Right. Compare that to drugs like atenolol or metoprolol. These are selective beta-1 blockers. They primarily target the heart.
So they slow the heart rate and lower blood pressure without affecting the lungs as much.
That's the goal, yes. Makes them generally safer for people with respiratory issues like asthma.
The material also mentions alpha blockers, often ending in Nozausen.
Yes, those specific examples weren't detailed beyond the naming convention. Alpha blockers target those alpha-1 receptors. By blocking them, they cause blood vessels to relax and dilate.
Which would lower blood pressure.
Exactly. That's a major use of hypertension. They're also used for benign prostatic hyperplasia, BPH, because blocking alpha-1 receptors relaxes the smooth muscle in the prostate and bladder neck, making it easier to urinate.
Okay, so these antagonists, beta blockers, alpha blockers, they're used when things are running too high. High blood pressure, angina, maybe fast heart rhythms, heart failure.
That's right. They counteract excessive sympathetic activity. Beta blockers reduce the heart's workload, lower heart rate, lower blood pressure. Alpha blockers focus more on relaxing blood vessels.
So side effects would be kind of the opposite of the agonists, feeling slowed down.
Generally, yes. Decreased heart rate, potentially too low bradycardia. Lower blood pressure, which can cause dizziness or fatigue, especially when standing up. That's orthostatic hypotension, particularly common with alpha blockers. Sometimes sexual dysfunction is reported too.
And with the non-selective beta blockers like propranolol, if they block beta-2.
Then you risk bronchoconstriction. That's why they have to be used very cautiously, if at all, in people with asthma or COPD, because blocking beta-2 can actually trigger an asthma attack.
Makes sense. Now, there was another really critical warning emphasized for beta blockers specifically, something about stopping them.
Yes, and this is incredibly important for anyone taking them. You should never stop taking beta blockers abruptly. Don't just decide to quit them cold turkey.
Why is that so dangerous?
Because your body gets used to the beta blockade. If you suddenly remove that blockade, you can get a rebound effect, a surge of sympathetic activity.
Which could mean
A sudden, dangerous spike in blood pressure, worsening chest pain or angina, potentially even a heart attack in susceptible individuals. It's serious.
wow. So tapering off slowly under medical supervision is essential.
Absolutely essential. That's a huge patient teaching point. Along with monitoring heart rate and blood pressure at home, understanding orthostatic hypotension precautions, and reporting side effects like excessive fatigue or signs of depression.
Okay. That covers the adrenergic side, fight or flight, agonists speed up, antagonists slow down. Let's completely switch gears now. The other side, the cholinergic system.
Right, the rest and digest system.
This one uses acetylcholine, HCO, as its main messenger, you said.
Correct. And the drugs we're focusing on here primarily interact with what are called muscarinic receptors.
Okay, so starting with the agonists again, cholinergic agonists. These would mimic the rest and digest response.
Exactly. They promote those functions. They're also called parasympathomimetics.
Mimicking the parasympathetic system. And a key example given was bethanical.
Yes, bethanical. It's a direct-acting agonist, meaning it binds straight to those muscarinic receptors and activates them.
And its main use mentioned was
Primarily for non-obstructive urinary retention. Basically, when someone can't empty their bladder properly, bethanical helps because it causes the bladder muscle, the detrusor muscle, to contract.
it squeezes the bladder to help urination.
That's the idea. So these agonists are used when you need a boost to those rest and digest type functions. Besides urinary retention, the material mentions uses like treating certain types of glaucoma.
How does that work?
By causing the pupil to constrict, that's called meiosis, which can help improve the drainage of fluid inside the eye, lowering the pressure.
Interesting. Other uses.
Also, potentially in conditions like myasthenia gravis, which involves muscle weakness, or even some approaches to Alzheimer's disease, as acetylcholine is involved in memory and cognition too, though the drugs might be different.
Okay, so if we think about the overall effects of boosting rest and digest, what does that look like system-wide? The sources had a nice summary.
Right, it's pretty much the opposite of fight or flight. You get decreased heart rate, increased activity in the GI tract, more movement, more secretions.
So more digestion?
Yes. Bladder contraction, leading to urination, pupil constriction, like we said for glaucoma, increased sweating, salivation, tear production, and potentially bronchoconstriction, narrowing of the airways.
That sounds like a lot. And the material gave us that acronym to remember the really pronounced side effects.
Yes, the memorable one, SLODGE.
SLODGE. Okay, what does that stand for?
It's a great way to remember the main signs of too much cholinergic stimulation: salivation, lacrimation, tears, urination, diarrhea, gastrointestinal cramping, and emesis vomiting.
Wow. SLEGE. That definitely paints a picture of, well, excessive secretions and activity.
It does. And you'd also see significant bradycardia, that slow heart rate, and potentially problematic bronchospasm or increased respiratory secretions.
So given those potential effects, it's pretty clear why these drugs wouldn't be good for someone who already has a slow heart rate or maybe low blood pressure.
Or asthma, COPD, peptic ulcer disease, anything where increased secretions or constriction would be bad.
Makes sense. So for someone taking these, what are the key things to monitor?
Definitely vital signs, especially heart rate and blood pressure. Watching fluid intake and output is important, especially with bethanical for urination. Monitoring GI function for diarrhea or cramping.
And practically maybe having a bathroom or commode easily accessible.
Good point, yes, because the urinary urgency can be significant. Taking it with food might help if there's GI upset, but critically, because too much of these drugs can lead to what's called a cholinergic crisis.
Which is basically severe SLA-DGE symptoms, right?
Yes, and potentially respiratory compromise. Because of that risk, it's essential to have the antidote readily available.
And the antidote is?
Atropine. Atropine blocks the muscarinic receptors, counteracting the effects of the cholinergic agonist.
Okay, atropine is the antidote. Now, you mentioned bethanical as direct-acting. The sources also brought up neostigmine as an indirect-acting agonist. What's the difference there?
Good question. So bethanical directly binds to the receptor. Neostigmine works differently. There's an enzyme in the body, acetylcholinesterase, whose job is to break down acetylcholine.
Okay.
Neostigmine inhibits that enzyme. It stops the enzyme from working.
So it doesn't stimulate the receptor itself, but it prevents the natural HEA from being broken down.
Exactly, which means more of the body's own acetylcholine hangs around in the synapse for longer, allowing it to stimulate the receptors more, so it boosts the effect indirectly.
And why is neostigmine important? What's it used for?
A primary use mentioned is for myasthenia gravis. That's an autoimmune disease where the body attacks acetylcholine receptors at the neuromuscular junction, leading to muscle weakness. Neostigmine helps by increasing the amount of HE available to stimulate the remaining functional receptors.
Yeah, okay. And that leads to this really important distinction the material made about a crisis state with neostigmine.
Yes, this is crucial in managing myasthenia gravis. You can have two opposing crises that might look similar initially because both involve severe muscle weakness, especially respiratory weakness.
Okay, what are they?
One is a myasthenic crisis. This happens when the patient has too little cholinergic stimulation, basically. Their disease is undertreated, or they didn't get enough neostigmine. They have profound weakness because there isn't enough AC activity at the muscles.
So they need more medication in that case?
Right, or a related treatment. The other crisis is a cholinergic crisis. This happens from too much medication, an overdose of neostigmine, or similar drug.
So they get the SLUGE symptoms on top of muscle weakness.
Exactly. You see, the SLGE affects excess secretions, diarrhea, bradycardia, plus muscle weakness, potentially due to the receptors being overstimulated and becoming refractory. And the excess respiratory secretions and bronchoconstriction can be life-threatening.
And knowing the difference is vital because the treatment is opposite.
Critically important. A myasthenic crisis needs more cholinergic support. A cholinergic crisis needs the drug stopped and, importantly, atropine administered as the antidote to counteract the excessive muscarinic effects like secretions and bradycardia.
Wow. Okay, that differentiation is key. So that covers the agonists.
Right.
Let's move to the final category, the cholinergic antagonists.
Yeah.
Also called anticholinergics or parasympatholytics.
Right. These drugs block the action of acetylcholine at the muscarinic receptors. They block the rest and digest system.
Which means the effects will be sort of like the fight or flight system is taking over.
In many ways, yes. By blocking the parasympathetic brakes, the sympathetic accelerator effects become more apparent.
And the prime example given here is atropine again.
Yes, atropine, the very same drug that's the antidote for cholinergic crisis. But it has its own primary uses when you want to block acetylcholine.
Like what?
A major one is treating symptomatic bradycardia, a dangerously slow heart rate. Atropine blocks the parasympathetic slowing effect on the heart, so the heart rate increases.
Gets the heart rate up quickly. What else?
It's used to dry up excessive respiratory secretions, maybe before surgery, to reduce the risk of aspiration. It's also used to dilate the pupils. That's mydriasis for eye examinations.
Okay. And other anticholinergic examples mentioned.
Yes, drugs for overactive bladder often ending in flomsin, like oxybutynin or tolterodine. They relax the bladder muscle. Also, certain medications used to reduce tremors and rigidity in Parkinson's disease, and common motion sickness medications like scopolamine patches.
So these drugs are used when you need to counteract or reduce those rest and digest effects.
Exactly. Treat severe bradycardia, dry up secretions, dilate pupils, calm an overactive bladder, reduce certain tremors, prevent motion sickness.
So if we think back to the SLDGE effects of the agonists, the antagonists would do the opposite.
Precisely. They increase heart rate, they decrease GI motility and secretions.
Leading to constipation and dry mouth.
Yes. They relax the bladder, which can lead to urinary retention. They dilate the pupils, causing blurred vision and sensitivity to light. They decrease sweating, salivation, and tearing, hence the dry mouth, dry eyes. And they can cause bronchodilation.
So instead of SLDGE, you get, like, the anti-SLDGE.
That's a perfect way to think about it. Dry mouth, blurred vision from pupil dilation, urinary retention, constipation, also tachycardia, fast heart rate.
And the sources mentioned confusion as well.
Yes, particularly in older adults. Atropine and some other anticholinergics can cross the blood-brain barrier and affect cognitive function, leading to confusion or delirium sometimes. And that light sensitivity photophobia is common because the pupils are wide open.
Okay, so because they block rest and digest, these drugs would be bad for people with certain conditions.
Definitely. They are generally contraindicated or used with extreme caution in people with glaucoma, especially narrow-angle glaucoma, because dilating the pupil can worsen the condition dramatically by blocking fluid drainage.
Increases eye pressure.
Right. Also, conditions involving obstructions in the GI or urinary tract, because they slow motility and can worsen constipation or urinary retention.
Like an enlarged prostate, BPH.
Exactly, making urination even harder. Also, people with existing tachycardia or certain heart diseases need caution. And interestingly, the sources note myasthenia gravis as a contraindication for some anticholinergics used for Parkinson's, as blocking acetylcholine could potentially worsen muscle weakness.
Got it. So for patient care and teaching with these drugs.
Monitoring vital signs again, especially heart rate, tracking intake and output, watching for urinary retention or constipation, managing the side effects is big.
Like the dry mouth.
Suggesting sips of water, sugar-free hard candy or gum. For dry eyes, maybe artificial tears. Warning patients about potential blurred vision and dizziness, increasing the risk for falls. Advising them to avoid strenuous activity in hot weather because they can't sweat effectively and might overheat.
And reporting serious effects like confusion or difficulty breathing.
Absolutely. Any signs of severe adverse effects need prompt attention.
Wow, okay. We've covered a lot of ground. Adrenergic, cholinergic, agonists, antagonists. Let's try to bring it all together.
Yeah.
Why is it really grasping these two systems and the agonist-antagonist concept so fundamental?
Because it's the absolute core framework. If you understand that adrenergic equals sympathetic, fight or flight, generally speeding things up, and cholinergic equals parasympathetic, rest and digest, generally promoting conservation or slowing things down.
And then whether the drug mimics that system, makes it stronger, like an agonist, or blocks it, like an antagonist.
Then you can logically predict the main actions of the drug, why it's being used, and what kinds of side effects you might reasonably expect. It provides a map to understanding a huge range of medications.
And these aren't just minor tweaks to the system, are they? These drugs affect really fundamental bodily functions.
They absolutely do. Heart rate, blood pressure, breathing, digestion, urination, the core automatic processes. That's why they're powerful tools for serious, sometimes life-threatening conditions.
But it's also why they require so much respect and care in their use. That high alert status for the IV alert adrenergic drugs really drives that home. The potential for harm is significant if they aren't used correctly.
Precisely. Careful monitoring, accurate dosing, knowing the contraindications and warnings, it's all non-negotiable.
And for you, the listener, having this knowledge, understanding whether your medication is supposed to speed you up or slow you down, recognizing patterns like SLDG or the anti-SLGE dry effects, knowing those critical warnings like never stopping beta blockers suddenly.
It empowers you, helps you understand your treatment, participate more actively in your care, recognize when things might be going wrong, and know when to seek help. It makes you a more informed partner in managing your health.
It gives you that mental map, like you said, to navigate how these drugs work with your body's own control systems.
Exactly. It demystifies a lot of pharmacology.
So, to leave you with a final thought, building on all this, consider the incredible precision that medicine aims for now. You have a drug like epinephrine, non-selective, hits multiple receptors, massive widespread effects, essential in a crisis, but lots of side effects. Then you have a drug like albuterol, highly selective for just beta-2 receptors in the lungs. It gives you the specific effect you want, opening the airways with far fewer unwanted effects elsewhere in the body.
It really highlights the difference between a broad approach and a targeted one.
It does. It underscores just how intricate that balance is within our autonomic nervous system, how finely tuned it is. And it shows how pharmacological tools have become increasingly sophisticated, allowing us to influence specific parts of that system with greater and greater accuracy, sometimes life-saving accuracy.
It's a fascinating interplay between understanding the body's complexity and developing targeted ways to intervene.
Indeed. And thank you for bringing us the sources that allowed us to take this really informative deep dive today.